Here are 5 tips for managing the pediatric difficult airway from open anesthesia. These tips and more information can be found on the open anesthesia summary on pediatric difficult airway, which can be accessed via this QR code. Open anesthesia summaries are updated versions of the open anesthesia keywords. Children have unique anatomic and physiologic features that may lead to a difficult intubation. Which brings me to my first tip. Learn to recognize the potential for a difficult airway. Not all pediatric difficult airways are the same. For example, midface hypoplasia is associated with difficult ventilation, while mandibular hypoplasia is associated with difficult intubation, and macroglossia is associated with both difficult ventilation and difficult intubation. One resource I would like to share with you is the Orphan Anesthesia website. It provides concise summaries of anesthetic management concerns for many syndromes that may be less familiar to anesthesiologists. I find that the easiest way to access orphan anesthesia is to type the syndrome with the phrase orphan anesthesia in your search engine. This will bring up a PDF of the syndrome in question, and you can scroll to the section on airway management. For example, one particular concern for Treacher-Collins syndrome is that difficult laryngoscopy becomes more difficult, not less difficult, with age. The open anesthesia summary I shared earlier also includes links to guidelines and frameworks for managing the pediatric difficult airway. This includes the ASA difficult airway algorithm, which was updated in 2022 to include pediatric patients. In this red box, you will find tip number 2, limit attempts to secure the airway. Why is it important to limit attempts on the airway? Because multiple attempts can lead to airway edema. Children have smaller airways than adults, and the same amount of swelling can lead to a marked increase in turbulent flow due to a smaller cross-sectional area. If you are having to make multiple attempts, consider giving an airway swelling dose of steroids early to prevent airway edema. This article was published by the Pediatric Difficult Airway or PD Registry. You can see on the left that direct laryngoscopy was most commonly used for the first attempt, followed by flexible fiber optic bronchoscopy, then video laryngoscopy. On the right, you see first attempt success, with direct laryngoscopy having only a 3% success rate. The takeaway here is, do not perform a direct laryngoscopy if you anticipate a difficult airway in a pediatric patient. After each failed intubation attempt, make sure you are making at least one of the following adjustments here. Which brings us to tip 4. Remember the definition of insanity, which is doing the same thing over and over again and expecting different results. The final tip is highlighted in red in the ASA difficult airway algorithm for pediatric patients. Remember to optimize oxygenation while managing the airway. Here are some ways to provide supplemental oxygenation during attempts to secure the airway. This does not have to be complicated. It can be as simple as a standard nasal cannula. Lastly, I want to share one bonus tip, which is to always optimize your intubation conditions, even when you don't anticipate a difficult airway. This open anesthesia summary provides an overview of how to optimize pediatric intubation. You can access it via this QR code on the right. It provides a great overview, including these 3 pillars of successful airway management in children. I hope you find these tips helpful. You can access more resources on managing the pediatric difficult airway on the Open Anesthesia website. This includes summaries and vodcasts, as well as Ask the Expert podcasts. Visit the Open Anesthesia website for free online access to comprehensive educational content on anesthesiology topics.